Great. We are back at the House Healthcare Committee for our last testimony of the morning. And we have with us Drew Hazelton, who's the Chief of Rescue Inc. with us. So this is again around a budget ask request. We do have a bill on the wall for EMS services that between us and hopefully government operations, we will find time to get to this year. But they have, so this ask is also in that bill, but because we're doing budget, it's better to hear of it now if we want to put it in our budget recommendation. So you'll introduce yourself for the record and then tell us your.
All right, so my name's Drew Hazelton. I am the Chief of Operations at Rescue Inc. I've been working in EMS for 26 years. I'm a critical care paramedic. I also serve as the chair of Vermont EMS Advisory Committee, and you have a report from the advisory committee as well, talking about kind of the health of our EMS system. And if it's okay, just kind of do a little overview of kind of where we're
have until noon. So.
All right. So Vermont's EMS system is pretty complicated. There's about 78 ambulance services, another 80 plus first response squads that do provide kind of immediate life-saving healthcare to all corners of Vermont. I would say we are the kind of the universal healthcare delivery model. When you call 911, it doesn't matter who you are or where you are, you will receive services. That system is in trouble in Vermont. That system has been in trouble for a long time, and certainly post-pandemic, we're seeing the crisis get worse. The crisis is being created by a challenging workforce dynamic, as well as increasing costs and static reimbursement rates. Medicaid rates for ambulance service providers hasn't changed since 2019. And needless to say, costs have been increasing significantly since then. In the paid ambulance service world, the cost of EMS labor has increased about 25% in the last 12 months alone, just to meet demand, very similar to what the hospitals, I'm sure, have come in and talked to you about. Trying to get EMS providers is difficult. In the world of our first response squads and our volunteers, we're still in Vermont asking our volunteers to not only commit their time, but commit their financial resources to serving their communities. Every year, there's a $150,000 appropriation through the EMS Special Fund that is made to providing EMS education to the entire state of Vermont. And $150,000 in education does not go far when we're trying to serve the 2,800 EMS providers in Vermont. Workforce turnover in Vermont is close to 30% in EMS. That's very consistent with the national averages. And certainly what we're seeing here is very similar to what we're seeing in other parts of the country. So that $150,000 we're using to try to provide not only initial education, but ongoing education and career development. And it's distributed through a system of grants to EMS districts. In the last couple of years, I should say last year, 2 years before that, we did receive some one-time money to help stand up EMS education programs. That money was used through a voucher program and grant programs that were issued by the Department of Health. With those programs, we were able to provide cost-free education to EMS providers in Vermont, and we had huge success with those programs. Once we removed the barrier of cost, we were able to bring our numbers back up to almost where they were. So as far as bringing people into EMS, reducing the costs, we were able to train about 300 EMTs versus where we were at before with the cost of education. So getting to the point of the budget ask, we need long-term, ongoing, sustainable education funds that will meet the needs of Vermont EMS providers. And we need to reimburse what it costs us to deliver those services. And I'm sure we're not the only healthcare providers that have been in here saying that.
You're the only one.
From the first. I'm the only one asking, that's easier for,
Right, exactly. You got it.
There's no automatic increase built into Medicaid rates for EMS. We come back every few years and, try to get something to help us support our ongoing challenges. So if we could get the Medicaid rates to in line with the Medicare rates, it is certainly not the end all. It's not going to fix the challenges in EMS, but it is a step in that direction. And if we can get that somehow to be increased with, some sort of factor so that we don't have to come back in every year and ask you guys to continue to increase those rates, we certainly appreciate that as well. So just a quick thing about how we get paid, because I think this is important. EMS was created 60 years ago in response to traffic accidents and traffic deaths, which is why in the federal world, we still live under the Department of Transportation. We also have a very antiquated system where EMS is actually paid to move patients. We're paid very similar to Uber or taxi cab, where we actually get paid by the mile. I would bet we're the only healthcare provider that gets paid by the mile. But what it means is that there's very little reimbursement for services that are provided to patients that don't result in transportation and mileage billed. In Vermont, there is a billing code that allows us to bill for patients that we treat, but we do not transport to the hospital under Vermont Medicaid. That billing code will pay 60%. The challenge is that code does not exist in Medicare. So if services are billing that code, they have to bill that code across the board. We can't bill simply low-income patients because they have Medicaid. We have to bill everybody. And what that does is it creates a burden, a financial burden to our seniors, because the health insurance that they carry does not cover the treat no transport in the way that Medicaid in Vermont does. So that system needs to be changed. That structure, the way that EMS is funded, needs to change. I know it's probably outside of the scope of Dave.
Right, I was gonna say, so that's at a federal level that needs to change for Medicare specifically, but.
There's other ways we can do it in Vermont, but I think it's probably more for the bill discussion.
Yep, okay.
It's probably today.
Yep.
Can you, obviously it's going to reject from Medicare. Are you allowed to bill the patient for it?
Yeah, since it's a non-covered service, those bills will then directly go to the seniors, which are quite often, fixed income folks that.
Okay.
So that's the challenge that EMS services have. So if you bill that code to try to reimburse or try to recover some of those costs, then those same people that you're trying to protect, we're putting in a difficult situation. And some choose to, some choose not to, but I just figured I'd kind of make everybody aware of kind of that reality.
Great. Mari?
Thanks for coming in today. Can you give us an example of a treat not transport? Is that like stabilizing someone who's having chest pain and then it goes away, you give them nitro and...
That would not be the one.
You'd want to send them to the hospital.
We'll want to get evaluated. A very common one would be a diabetic, where we can very easily correct a low blood sugar scenario by showing up and helping, taking their blood sugar, starting an IVA, giving them medications, and then there's really no reason they need to go to an emergency room. They can follow up with their own primary physician after that. That's a very common one. A fair amount of smaller type incidents, because EMS doesn't only get called for life-threatening emergencies. We sometimes and quite often get called for less emergent. So that may be something as simple as bandaging up a wound or splinting a fracture and then having those patients go by private vehicle to the hospital, because there's not indication for an ambulance transport. But that work, those supplies, that equipment would be non-reimbursable.
And then if you have a COVID patient or someone with the flu, some other infectious disease, there's a different protocol for cleaning out the rig if you do transport somebody. And that adds expense?
It does. So during the pandemic, every patient, so in our organization, we utilized chemicals as well as ozone, and every patient interaction required an hour of decontamination for every ambulance. So we had the luxury of having 11 ambulances. So every ambulance crew was assigned 2, and they would go out in a call-in one and sterilize and run the other one where they sterilize the first. So yeah, that again adds expense as well as the chemicals and the ozone break down the inside of the ambulances at a rapid rate too. So during the pandemic, we certainly did a lot of damage to equipment just from that.
Hopper and then Leslie.
From my understanding, EMS that you're talking about is different from, say, Barrytown's ambulance service. Am I correct in that?
Different from what perspective?
Well, you said you had 11 ambulances.
Yes. So so the EMS is delivered in different ways across the state. So where Rescue Inc. in Brattleboro and Townsend, we serve 14 communities. We're a regional nonprofit. So we cover about 500 square miles. So we have a fair amount more personnel and equipment. Then we have smaller services that may serve a single community that may only have 1 or 2 ambulances. And we have really everything in between in Vermont. And we say if you've seen one ambulance service, you've seen exactly.
Hear that a lot here.
That's not my joke. It is. I stole from someone else. That's why I like
Everyone's heard it, so I like to put it back out there. But it's real, and every delivery model is different. So in the municipal models, those services are directly funded through the municipalities. And through like the nonprofit model that I work under, we receive assessments from those communities. So even though it's not a direct tax, it is coming from the property taxes. And what is happening at this point is every time the costs go up, but our reimbursement rates don't go up, we're subsidizing the Medicaid program through municipal property taxes, and we're leaving our federal match on the table. And that's been happening year after year after year. So,
And you're here, maybe I should have been more clear. You are here speaking on behalf of all EMS for the state. So for instance, our EMS is Essex, in Essex. They would also like reimbursement rates. And I am sure every single one of your EMS services around this table and through the state want increased reimbursement rates. So he's representing Rescue Inc.
That's what I was trying to get.
Yeah,
I'm sorry, yes.
that's my apology for not laying that out. Yes.
I misunderstood the question. Yes, I chair the advisory committee, and I'm here in the role as the chair of the advisory committee. This was our number 1 challenge and certainly ask for this year. And number 2 would be funding for education.
Yeah.
So those are our 2.
We have Leslie, Art, and then Alan.
I was just thinking about calls that you do for people who are struggling with mental health issues and how you interact with that. And does that necessarily require transport? So maybe you can stabilize. I'm just wondering how that works.
So currently in EMS, the only place that we can transport patients to is a local emergency department. So if we are called to a patient that's having a mental health crisis, we don't have alternatives other than to take them to the local emergency department, which we all know is probably not the best solution for them. The secondary component of that is at a later time, those patients are generally needing transportation by ambulance to a mental health facility. One of the areas of concern in the Medicaid reimbursement rates is the rate for transporting patients from that hospital to a mental health facility are extremely low, and low to the point where it makes it impossible a lot of times to get ambulances to be able to do those because of the losses associated with taking those patients. So mental health are specifically challenging.
In one of the components of the bill that's on the wall is the being able to transfer to not an ED. So we've heard some testimony like from the Northeast Kingdom, they're looking to do that therapeutic alternative to an ED. So right now, the way everything's written, the EMS would not be able to transport someone to that therapeutic alternative. And that is something that we would like to look at. I would like to look at.
May I just It's very quick. So that problem of not reimbursement is woven into your request for increase? Okay, I was just wanting to make sure I was coming.
I forget. I think Art and then Alan.
Yeah, I didn't know if you can put any numbers to this.
So the education ask is $1 million. That's what we've determined it takes to
It's
maintain.
150K right now?
Yes.
Okay, so you want to go to 1 million, all right.
And my best estimate, though you have an expert in the room, based on what we know from our research, is that it's probably in the $3.5 million range to increase Medicaid to the Medicare. But I will certainly yield to the expert in the room.
So right, so the estimate, we are waiting on actual numbers. The estimate, what we're thinking it might be is about $3.1 million to get to 100% of Medicare. But we're going to get some numbers like we are for everything else we've heard, and we'll have it ready for discussion.
Because wasn't that was something like we said is not coupled with
It isn't.
Medicare, correct?
So it
Service.
was actually, so when we went through the rates yesterday, it was
Yeah.
in the ambulance service line.
Right.
And so it is right now at 76% of Medicare.
Okay, that was it. Okay, that was it.
And it has not changed since 2019, which means even if Medicare has increased, they have not changed our rate. So really now it's like 70%
70%.
of Medicare.
Gotcha, I recall.
Yeah. Hold on, Alan?
I got a little confused there when you said you had 11 ambulances. Are you EMS in every county or community?
So in our service area, we serve 14 towns with 11
You
ambulances.
said that. What about the rest of the state?
There are 76 total ambulance services in Vermont, 78.
So for your community, so
Okay.
if we increase rates, it would increase rates for all EMS
Okay,
in
that's-
the state.
okay,
Yes,
that's-
yes,
Yes, please do that.
yes. Hold on, Topper.
The education ask,
Yes.
if, let's say it happened, does that mean that a place like Barrington that now pays for the education, would they be included in that and not have to pay for the education?
Yeah, so the way that the program has worked in the last couple of years is through a voucher type program where students or services could apply. And then through the health department, with help from the advisory committee, they identified underserved areas of Vermont where there may not be access to education programs because they don't have the instructors or the infrastructure. And in those areas, there were very targeted programs. So the short answer to your question is yes, it would apply to every EMS provider in the state. And it would be initial education, ongoing education. Every EMS provider has to get a certain amount of ongoing education every other year to maintain their license. And it would be upgrading service or providers. So for example, we introduced a new license level a year ago, the Vermont Responder. It was an entry level that came through this committee, I'm sure probably a couple of years ago. That's an entry level position. And what we're seeing in that is a lot of interest. 400 plus people came in as entry level Vermont responders that are now looking to become EMTs. And this money would be used to help them upgrade their certification to become an EMT as they move forward.
An effective program.
So far, it's been very
Do
effective.
you have, without having to do work, do you have any data through your position on the advisory to send us on the success of what we did
Absolutely can.
previously? Okay, that'd be great. If you can send it,
See all the numbers.
okay, if you can send it to committee assistant, that'd be great. Are you good?
I'm good.
Art,
I'm all set.
you're all set. Anyone else have any questions? Or Drew, any last thing to add?
So, and I know it'll come up later as part of the bill, but the advisory committee has been working for quite a few years. And one of the challenges that we struggle with is that the ambulance services in Vermont and the first response squads don't have a lot of administrative capacity. Many of these services are very, very small. And as we seek information in order to be able to provide data to you, we struggle to get that. So one of the things that's in the bill that I would also ask that you include is money to hire a consultant to dig into really those specific needs that we can't we don't have the bandwidth to do. So the EMS advisory committee would like to provide more detailed information. We need some help. And in the bill, there's funding to help to hire a consultant to kind of help us put that information together. So I'd ask that you'd include that if it's possible as well.
So I'm trying to get the number of the, so H263, just so everyone has it. If you look on that, there is language for a study. And what I would like to do is, as part of our budget discussion, talk about pulling it out of that bill and putting it in the budget as an option so that we can get the study started. You know, we don't know the timeline or process of the bill. So we're going to add that to our chart. Again, we'll talk about it all and make some decisions, but it's H263 if you want to take a look at it. So thank you for that. Potentially 3.4 million. So you were very close.
Well, that's my back of the envelope.
Potential, right? We're not.
It's in the ballpark.
Yeah, I gotta hear back from GMSC.
So we'll get all these rates.
So it's
all this-
approximately 3.5 million, right?
Yeah, approximately.
Yeah, I give, that's my back of the envelope, but I went to confirmation.
Yeah.
But that'll be our proxy.
One other quick question.
Sure, go ahead.
So my region is served by Calix, Caledonia and Essex, the Advent Company. Do they have any unique issues that you know of that because of our rural area? Because they serve 2 counties, Essex and Caledonia, so.
So unique to Vermont in the way that Vermont exists? Yes. So they're a rural EMS service. So one of the challenges with rural EMS is distance. So everybody wants an ambulance when they want an ambulance. So trying to make sure those response times are reasonable. And then the call volume in a lot of areas, rural areas, is low. So what we call the cost of readiness is very high. So the amount of time that equipment is in service and staff is paid to be available is much higher versus, say, downtown Burlington, where there's a lot more higher call volume. So what's unique to those rural services is a really high cost of readiness, which makes their budgeting much more complicated, much more difficult to kind of achieve those. And like many services, I'm sure they're probably fundraising and trying to subsidize the delivery of that healthcare through volunteers and through fundraising dollars and through grants.
I know in our community, we can subscribe we have a yearly subscription option that we can subscribe to our EMS. And I will say, I spent quite a bit of time with our EMS a couple months ago with our, and it's really fascinating to hear what they do, what they're required to do, what they don't get paid for, and where they are in our system of care. So, I'm sure any one of your EMS groups would be happy to talk to you if you have questions, and it might be helpful background, when we get to the point of taking up the bill at some point. So.
But I just mentioned it because on my town meetings almost every year, there's a floor amendment to add more money to the Calix request. And my campaign treasurer does the bookkeeping for Calix. So.
Okay, yeah, right, yeah.
So I know a bit about that, but I'm just curious if there's any specific things, but other than what we know about distance in rural areas. So.
Yeah.
Well, thank you. No, I appreciate that.
For some of the rural areas, someone might come out to the call in their own car.
I would say that
Got
happens.
their bag and everything. My brother
Halfway.
does that.
I would say in almost all communities in Vermont. I'd say there's less communities that don't have that than there are communities that do.
Yeah.
Interesting, yeah. Well, thank you for coming in and taking the time. We will seriously consider this, and I'm sure we'll be talking to you over the course of the year as well.
Thank you.
Thank you for all you do. Yes. All right, we can